Welcome back to the Deep Dive. Today we are plunging into a topic that's absolutely crucial for anyone revising medical knowledge, specifically for areas like the MSRA.
hmm
We're taking a set of detailed revision notes on frontotemporal dementia, FTD for short, and our mission is, well, to unlock them.
Yeah, to make sense of it all.
Exactly. We're going to extract the absolute high-yield nuggets,
hmm
clarify the complex bits, and really make this material stick for you. We'll cover everything from, what it is to how it's diagnosed and managed.
And it's particularly vital because FTD represents a pretty significant chunk of dementia cases, especially in a demographic that often surprises people, those under 65.
Right.
Understanding its unique features is really key to telling it apart from other conditions.
Definitely. So let's get straight to it. We'll navigate the definition, causes, symptoms, all the practical stuff for FTD, using these revision notes as our guide, but aiming for something, well, a bit more engaging than just reading bullet points. Okay, let's start by getting our arms around what frontotemporal dementia fundamentally is.
Okay, so at its core, FTD is a progressive neurodegenerative disorder. The name itself gives you a clue.
Tells you where it hits.
Exactly. It primarily affects the frontal and temporal lobes of the brain.
And unlike perhaps what many people first think of with dementia, like, say, memory loss, what's the main impact when those specific areas are affected?
That's the crucial distinction, really. Because it hits the frontal and temporal lobes, the main impact is on behavior, personality, language abilities,
Okay.
and executive functions, things like planning, decision-making, problem-solving.
Right.
Memory impairment is typically not the initial or most prominent symptom. That's a major clue when you're trying to differentiate it.
The difference in presentation is really striking.
Hmm.
What about the underlying causes? We often hear about genetic links in these kinds of conditions.
Yes, absolutely. Genetics plays a significant role in, well, a proportion of FTD cases. Specific gene mutations are linked.
Which ones should we know?
Notably in C9orr72, MAPT, which is involved with the tau protein, and PGRN, that one's linked to progranulin protein.
Okay.
And it's worth remembering, maybe for revision, that mutations in the MAPT, the tau gene, and PGRN, the progranulin one, are specifically found on chromosome 17.
Chromosome 17. Got it. And you mentioned the age group earlier. This isn't just an older person's disease then.
Far from it. A key characteristic is the typical onset around the mid-50s.
Wow. Yeah.
So this makes it a leading cause of dementia diagnosed before age 65. The trajectory, though, can be variable. Survival after symptoms start ranges anywhere from, say, 3 to 21 years.
So it's a condition with quite a broad spectrum, both in how it looks and how it progresses. The notes call it a heterogeneous syndrome. What should we take away from that term?
It just means FTD isn't one single uniform thing. It's really a group of clinical syndromes, all stemming from that degeneration in the frontal and anterior temporal lobes, but they can present in different ways initially. For instance, Pick's disease is one specific pathological type that falls under the broader FTD clinical umbrella.
Okay, so for you, the listener, understanding this initial definition, where in the brain it hits, how it affects behavior and language first, the typical younger age of onset, and that it's a kind of group of conditions that provides the foundation. It sets the stage for recognizing the different ways FTD can show up. Knowing what FTD is, the natural next question is, why does it happen? What do we know about its causes or, the etiology?
Well, the precise cause remains uncertain in many cases, which is pretty common with neurodegenerative diseases.
Right.
It's thought to be a complex interplay, likely involving both genetic factors and potentially environmental ones, too.
So while we just talked about those specific gene mutations, that's not the whole story.
Exactly. While some cases are clearly linked to those specific genes like MAPT, GRN, and C9orr72, a significant number are, well, sporadic, meaning they don't have an identifiable genetic cause tied to those known genes. We don't know exactly why they start.
Okay, so it's not exclusively genetic, but genetics are definitely a known piece of the puzzle for some. For revision purposes, how does thinking about the cause help us?
It frames our understanding that while we can identify risk factors or the underlying pathology, the initial trigger isn't always clear. It also sort of highlights where the research is heading.
Trying to figure out the why.
Yeah, trying to understand those genetic links better and maybe identify potential environmental influences down the line.
And this leads us right into risk factors. Are there specific things that make someone more susceptible to developing FTD.
Yes, the material flags up a few key risk factors to be aware of.
Okay.
A strong family history of FTD is definitely a significant one.
Right, that makes sense.
And as we just mentioned, carrying one of those specific genetic mutations, the C9orf72, MAPT, or GRN genes, that substantially increases risk.
Okay.
And a personal or family history of other neurodegenerative disorders is also noted as potentially increasing susceptibility.
So if you're taking a history and you hear about dementia in a younger relative, or maybe other related neurological conditions floating around in the family, this should definitely make you think about FTD. That family history piece sounds really key.
It really is. It's a major red flag.
Let's look under the hood now. What's actually happening in the brain at a biological level? The pathophysiology.
Right. This is where the abnormal protein accumulation comes in. FTD involves the buildup of specific proteins inside brain cells.
Like what kind of proteins?
Most commonly tau and TDP43, but also another one called FUS in some subtypes.
And its buildup is like toxic. It causes problems.
Yes, exactly. These abnormal protein inclusions, it lead to the degeneration and death of brain cells.
Specifically in those front and temporal lobes.
Primarily concentrated there, yes, which, as we discussed, aligns perfectly with where the symptoms manifest.
Makes sense.
Now, while we know the proteins involved, the exact step-by-step mechanisms of why they accumulate and how they actually cause this degeneration, well, they aren't fully understood yet.
Still some mysteries there.
Definitely, but for revision, understanding the histological classification is important. FTLD, frontotemporal lobar degeneration, that's the pathological term. It refers to the atrophy, the shrinkage in the frontal and temporal lobes.
Okay.
And this pathology is then categorized based on which protein has built up. So there's FTLD-TAU, where the main protein is tau. This is linked to specific clinical syndromes we'll get to, like corticobasal degeneration, CBD, Pick's disease, PID, and progressive supranuclear palsy, PSP.
Right.
Then there's FTLD-TDP, involving the TDP43 protein. This one even has further pathological subtypes, A through D.
Complex.
It is. And finally, FTLD-FUS, where the FUS protein is found, associated with the condition called AFTLDU.
And the genetic links tie into these.
Often, yes. The genetic mutations we talked about often link specifically to one of these pathological subtypes.
Okay, so the core issue is abnormal protein buildup causing cell death. And knowing which protein is key to classifying the specific FTLD pathology.
Yeah.
That helps us understand the biological reason behind the different ways FTD can present clinically. Like the proteins tau, TDP43, FUS are the specific molecular culprits driving it all.
That's a great way to think about it.
Now, this is arguably one of the most challenging parts, I think, from a revision standpoint. How do you tell FTD apart from other conditions that might look similar? The differential diagnosis.
It is challenging, absolutely, because FTD's initial symptoms can overlap with a really wide range of other neurological and even psychiatric conditions.
So you need a big list.
You really do need to consider a broad list to avoid misdiagnosis. The material gives us a comprehensive one. Maybe to make it more manageable for revision, we could think about grouping them.
Good idea.
Okay, so first, you need to rule out other neurodegenerative causes. The big one, the most common, is Alzheimer's disease.
Right.
But also think about Huntington's disease or prion diseases like CJD.
Okay, other dementias or similar conditions, what else?
Then there are structural or vascular issues affecting those frontal lobes. Things like cerebrovascular disease, including specific strokes, maybe tumors or hydrocephalus.
Things taking up space or affecting blood flow.
Exactly. Then infections are critical to rule out, especially ones that hit the brain. HIV leading to AIDS dementia complex. Herpes simplex encephalitis, tertiary neurosyphilis, even Lyme disease.
Okay, infections, got it.
You also need to consider inflammatory or autoimmune conditions like multiple sclerosis or maybe things identified by markers like ANF.
Right.
And crucially, always think about reversible or treatable causes, metabolic disturbances, nutritional deficiencies like B12 or folate.
The ones you can fix.
Yes, also substance abuse.
And finally, what about psychiatric overlap?
That's a big one. Given the prominent behavioral changes in BVFTD, primary psychiatric illnesses are often on the differential diagnosis list, particularly early on.
Wow, that's a heck of a list. For someone faced with a patient, how do you even begin to navigate that? What's the first step in reeling things out based on the FTD symptoms we've already talked about?
That's a great question. The first step is always the detailed history and examination. You're looking for clues that point away from typical FTD.
Like what?
For example, if memory loss started first and is really the most severe symptom, Alzheimer's is much, much higher on your list than FTD.
Okay.
If symptoms came on very suddenly or they fluctuate a lot, you're thinking more about maybe a vascular event or something acute like an infection or a metabolic issue, not the usually gradual decline of FTD.
Makes sense.
If there are prominent motor symptoms right from the start without clear behavioral or language issues yet, that might push Huntington's or MND higher up the list.
And psychiatric.
Psychiatric illness usually lacks the specific progressive cognitive deficits you see developing in FTD over time. Although, admittedly, the initial behavioral changes can look very similar.
So it's about pattern recognition.
Exactly. Finding the best fit symptom pattern and then using investigations, which we'll get to confirm or exclude possibilities.
So use the characteristics of FTD's presentation, the age, the progressive nature, the pattern of behavior language first, memory later, to start pruning that big list.
That's the approach.
Okay, what's the bigger picture for FTD? How common is it? Let's look at the epidemiology.
Right. It might not be as widely recognized as Alzheimer's by the general public, maybe, but FTD is significant, especially in those younger age groups.
That's significant.
According to the information here, it's the second most common cause of dementia under age 65 in the UK.
Wow, second most common under 65. That statistic alone really underlines why it's essential to know about FTD for anyone in training or practice.
Absolutely. The estimated prevalence is around 15 to 22 cases per 100,000 people.
Okay.
And the notes also suggest this is likely an underestimate.
Why is that?
Because, as we've discussed, it can be underdiagnosed or misdiagnosed, especially early on when behavioral symptoms might be just put down to psychiatric conditions.
Right.
Reconfirming the onset around the mid-50s really reinforces its importance in working-age populations. And about 10–15% of cases are linked to an autosomal dominant genetic mutation.
Which ties back to the genetics and risk factors we talked about.
Exactly.
So for revision, key points. FTD is not rare. It's a major cause of early onset dementia, and the actual prevalence might even be higher than reported. Good to keep in mind.
Definitely.
Let's talk about what you'd actually see in someone with FTD. The clinical presentation, signs, and symptoms.
Okay, this is where the rubber meets the road, isn't it?
Yeah.
As we mentioned, FTD is defined by a range of cognitive and behavioral changes. Often the personality and behavioral alterations are the most striking early features.
Like what specifically?
Loss of social conduct, disinhibition, changes in empathy or motivation. Language difficulties are also very common, either problems producing speech or understanding it.
Right.
Executive dysfunction, so difficulty with planning, organization that's prominent too. And apathy.
Just a lack of drive.
Yeah, lack of drive or indifference. That's frequently seen.
And memory isn't the headline feature.
Precisely. Memory loss is usually not significant in the early stages. That's a key differential point from Alzheimer's again.
Okay. What else might you see?
Well, beyond those core symptoms, the notes list other possible signs. Impulsivity, maybe inappropriate behavior, compulsive or ritualistic actions.
Repetitive things.
Yes. And noticeable changes in appetite or food preferences, sometimes developing a real sweet tooth, for example.
Interesting.
And interestingly, up to 50% of cases might also present with some symptoms of Parkinsonism.
Like stiffness or tremor.
Stiffness, slowness, sometimes tremor, yeah. On neurological exam, you might eventually see things like primitive reflexes returning.
Like baby reflexes.
Kind of, yes.
What?
And sometimes the disinhibited behavior is apparent right there during the consultation itself.
Okay, now the notes categorize FTD into 3 main clinical syndromes based on the predominant symptom at onset. This seems like a really practical way to think about how FTD first shows up. Let's break those down. First, the most common presentation. Behavioral variant FTD, or BVFTD.
Right. In BVFTD, the defining feature is that change in personality and behavior. You see loss of inhibition leading to inappropriate social behavior.
Saying or doing things out of character.
Exactly. Also, loss of motivation without necessarily being depressed, repetitive behaviors like hoarding or specific routines and difficulties with planning and decision-making. The behavioral changes are usually more obvious than any cognitive deficits early on.
So, key for revision.
Oh.
If you're presented with a scenario where personality change, inappropriate actions, or strange new habits are the main issue, immediately think BVFTD.
Okay, what's a second syndrome?
That's semantic dementia. This one is primarily a language disorder.
How does that present?
Patients lose vocabulary and the meaning of words, even though their speech might still sound fluent.
Well,
It's sometimes called empty speech.
fluent but empty.
Yeah, They struggle to find the right words or name objects, and they can lose the ability to recognize familiar faces or objects because they lose the meaning associated with them.
Wow.
Importantly, memory and visual spatial skills are relatively preserved, especially early on. Okay. Fluent speech, but trouble with meaning and naming. That's semantic dementia. And the third syndrome.
Progressive non-fluent aphasia. So this is kind of the opposite type of language problem. Here, speech production is the issue.
How so?
It becomes slow, hesitant, really effortful. There are grammatical errors, difficulty understanding complex sentences, and often a loss of reading or writing skills.
And on exam.
On examination, you might notice difficulties with the actual physical movements needed for speech, sometimes resulting in things like stuttering.
Okay, so effortful, halting, grammatical speech problems. Progressive non-fluent aphasia. Right. For revision, thinking about which domain is hit first, behavior, BVFTD, meaning of words with fluent output, semantic, or speech production with non-fluent output, PNFA, seems like a great way to distinguish these three core syndromes.
It's an excellent mental checklist, and just to make things a bit more complex.
Oh, good.
Yeah. These syndromes can overlap with other neurodegenerative conditions, forming what we call overlap syndromes. The notes mention overlaps with a few key ones. Progressive supranuclear palsy, PSP, that's characterized by issues like vertical gaze impairment, difficulty looking up or down, problems with balance leading to falls, and additional behavioral or cognitive changes.
Okay, PSP.
Corticobasal syndrome, CBS. This often presents with asymmetric motor symptoms worse on one side, like apraxia.
Difficulty with movement.
Yeah, difficulty with learned movements, like using tools. Also rigidity and involuntary jerks called myoclonus.
Okay, CBS.
And motor neuron disease, MND or ALS. Here you see the motor symptoms characteristic of MND, like muscle weakness, twitching.
Oh.
The notes mention fasciculations, particularly in the upper arms, as a possible early sign,
Right.
alongside the behavioral or language problems of FTD. Cognitive and behavioral changes can definitely occur in MND itself, too.
So the lines can blur.
They certainly can. Generally, these overlap syndromes might involve Parkinsonian symptoms, rigidity, apraxia, dystonia, or other motor changes alongside the core FTD features.
All right, we've got a handle on the clinical pictures. Now, how do we actually confirm the diagnosis or rule out all those other possibilities we talked about? This is the investigations phase.
Yeah, the diagnostic process is really multimodal. It starts with a comprehensive clinical assessment.
History and exam.
Exactly. Taking a detailed medical history from the patient and, crucially, from someone who knows them well, a family member, a friend.
Collateral history is key.
Absolutely essential in dementia. Then conducting thorough neuropsychological evaluations to map out the specific cognitive strengths and weaknesses, and of course, a detailed neurological examination.
What about imaging?
Brain imaging is essential. MRI is generally preferred because it's best at visualizing that characteristic frontal and temporal lobe atrophy or shrinkage.
Other than CT.
Yes, while CT scans can be used, they might miss more subtle changes, especially early on.
Okay, MRI first line. What about genetics?
Genetic testing for those specific FTD-associated mutations we mentioned, C9orf72, MAPT, GRN, that should definitely be considered, especially if there's a strong family history or the clinical picture strongly suggests a genetic form.
And what about all those blood tests to rule out the mimics?
Yes, that's a crucial step in working up any suspected dementia. You absolutely need to screen for reversible or treatable causes and other conditions that could look like FTD.
It's the standard stuff.
Pretty standard labs, yeah. Full blood count, FBC, to check for anemia, ESR and CRP for inflammation, UNEs for kidney function and electrolytes, LFTs for liver function. Critically important to check serum B12 and folate levels for deficiencies.
Right.
Also, screening for infections that can affect cognition, like HIV and syphilis tests. The notes mention broader dementia screening tests like ANF and TPHA if they seem appropriate, and maybe specific tests based on symptom presentation, for instance, if there's suspicion of encephalopathy or Parkinsonism.
So baseline bloods.
Yeah.
Rule out nutritional, metabolic, inflammatory, and infectious causes.
Yeah.
What about CSF, spinal fluid?
Cerebrospinal fluid testing, done via lumbar puncture, is sometimes performed by specialists. It's not always routine.
But it can help.
It can be particularly helpful in distinguishing FTD from Alzheimer's disease because the protein pathologies are different, and you can sometimes measure biomarkers related to those proteins in the CSF.
Okay. Anything else on imaging?
Yes, metabolic brain imaging, things like FDG-PET or perfusion SPECT scans. These can show patterns of brain activity and metabolism or blood flow that are characteristic of FTD.
So they show function, not just structure.
Exactly. They can help support the diagnosis or pinpoint the location of the pathology, especially if standard MRI isn't totally clear. Nice guidelines suggest considering these if FTD is suspected, but imaging isn't definitive. However, and this is a really important point from the notes, you should not rule out FTD based solely on imaging results.
Clinical picture is king.
The clinical picture and the history remain paramount. Imaging supports the diagnosis. It doesn't make it on its own if the story doesn't fit.
Right. So this gives us a clear pathway for investigation. Clinical assessment first, then imaging and targeted blood tests to rule out mimics, with genetics or CSF, maybe considered in specific cases.
That sums it up well.
Okay, once FTD is diagnosed, what can actually be done? Is there a cure? This brings us to management.
Unfortunately, no. At present, there is no cure for frontotemporal dementia. The focus of management is entirely on managing the symptoms and providing really comprehensive support.
For patient and family.
For both the patient and their caregivers, absolutely. Overall management involves addressing the behavioral and psychological symptoms that cause distress.
The really difficult parts often.
Often, yes. Using both medications and, crucially, non-prescribing strategies. And multidisciplinary care involving various specialists is pretty essential because the symptoms are so diverse.
So medications are used, but just for symptom control.
Exactly. Medications are used to target specific troublesome symptoms. For example, benzodiazepines might be used very cautiously for, say, acute aggression or agitation. SSRIs, the antidepressants, are sometimes used for compulsive symptoms, although the evidence isn't always that strong. Medications like valproate semisodium might help with mood symptoms or impulsivity.
Interesting.
Topiramate is sometimes used to suppress those appetite changes we mentioned, if they become problematic. Atypical antipsychotics might be considered for very challenging behaviors, but the notes strongly caution against their use.
Why caution?
Because of significant potential side effects and increased risks. Particularly in older adults and those with dementia, they need very careful consideration.
Right.
If Parkinsonian symptoms are prominent, then medications like levodopa-carbidopa or dopamine agonists might be tried. And it's also really important to review all existing medications and stop any that could potentially worsen cognitive confusion.
Deprescribing.
Precisely.
And the non-prescribing management sounds just as vital, maybe even more so, especially given the behavioral focus of FTD.
It absolutely is. This includes extensive education for both the patient, while they can participate, and their family or caregivers about the disease, its progression, what to expect.
Managing expectations?
Yes, and planning for the future. That's critical. Introducing discussion around lasting power of attorney for both health and finances should be considered early on, while the person still has capacity to make those decisions.
Good point.
As the disease progresses, care needs increase dramatically, and the challenging behaviors can lead to significant caregiver strain. Recognizing this and providing psychological support, maybe arranging respite care or helping get additional caregivers in place, is paramount.
That multidisciplinary team comes in here.
Exactly. That team approach helps coordinate everything from speech therapy for communication issues to occupational therapy for daily living, psychological support, social work, safety planning, the whole package.
So the management isn't about reversing the disease. It's about maximizing safety, well-being, and quality of life for the patient, and providing absolutely essential support for those caring for them. Medications target specific symptoms, but there's a huge emphasis on non-pharmacological strategies and caregiver support.
That captures it perfectly.
We touched on the variability earlier, but let's look more closely now at the prognosis. What's the outlook like?
Yeah, the prognosis is indeed variable. It depends significantly on the specific FTD subtype and other individual factors. On average, though, the survival time noted in the material is around 6 to 10 years from the onset of symptoms.
How does that compare to something like Alzheimer's? Is it faster, slower?
The information suggests it actually has a similar life expectancy to Alzheimer's disease overall.
Okay.
The disease course itself involves a gradual progressive decline across social functioning, cognitive abilities, and neurological status.
Leading to more dependence.
Ultimately, yes, leading to complete dependence on caregivers for all daily activities. There are some specific variations in survival based on the subtype or those overlap syndromes we discussed. The semantic dementia type seems to have a somewhat better prognosis, often exceeding 10 years.
Oh.
However, if FTD overlaps with motor neuron disease, the prognosis is significantly poorer, typically ranging from just 3 to 5 years.
Big difference.
Huge difference. It's also noted that as the disease progresses, the distinctions between those initial clinical syndromes, BVFTD, semantic non-fluent aphasia, they can become less clear.
Why that?
As more brain areas become affected, the symptoms tend to converge and the presentation becomes more globally impaired.
We've mentioned the family impact multiple times, but specifically highlighted under prognosis too, isn't it?
Yes, and it's worth reiterating. The behavioral changes, the communication loss, combined with increasing physical disability, make FTD particularly challenging for families and caregivers. Understanding the potential trajectory, even though it's difficult news, is really important for planning and getting the right support in place.
Absolutely. Finally then, what are the specific problems or challenges that tend to arise as FTD progresses? The complications.
These complications are essentially the direct consequences of that progressive brain degeneration.
Makes sense.
Difficulty in daily activities is a major one, meaning the person becomes increasingly unable to manage personal care, household tasks, finances, everything really, impacting their daily functioning profoundly.
Okay.
The behavioral issues and communication impairments we've talked so much about, they can become more severe and complex over time, leading to really significant behavioral challenges for caregivers to manage.
Right.
This increasing loss of independence leads directly to increased reliance on caregivers, highlighting that caregiver dependency aspect.
Which links back to management needing to support them.
Exactly. It's a cycle. And as the disease advances, overall physical health tends to decline. Individuals become more vulnerable to other medical problems.
Like infections.
Infections are common, like pneumonia, often related to swallowing difficulties later on, or injuries from falls, maybe due to motor problems or impulsive behavior. This increased medical vulnerability is a key complication.
Okay. These complications really drive home the profound impact of FTD on daily life and the huge burden it places on families, which just reinforces the importance of all those supportive management strategies we discussed.
Absolutely, they are intertwined.
All right, we've completed our deep dive into frontotemporal dementia. We've covered a lot of ground, from defining what it is, exploring its potential causes, and the underlying pathology.
The proteins.
Yeah, the proteins. Differentiating it from other conditions, understanding its epidemiology, especially that under 65 aspect, recognizing its varied clinical presentations and those tricky overlap syndromes.
Then outlining the diagnostic steps, detailing the management strategies, both meds and non-meds.
And finally, discussing the prognosis and complications.
We hope that by breaking down these key areas and really highlighting the distinctions like the behavior language focus versus memory in Alzheimer's, or the differences between BVFTD, semantic dementia, and progressive non-fluent aphasia, we've helped make this complex condition a bit more digestible, maybe more memorable for your revision.
Yeah, it's clear FTD is a distinct progressive neurodegenerative disorder. It has a huge impact, particularly on younger individuals, and presents unique diagnostic and management challenges because of its varied symptoms, especially those behavioral changes.
And thinking ahead, given the ongoing research into the specific protein pathologies and genetics, particularly for things like GRN mutations and maybe potential therapies targeting progranulin levels,
Right, that research mentioned.
how might the future of diagnosis shift? Could it move away from purely clinical observation towards incorporating more biomarkers, maybe genetic screens earlier on?
And what potential opportunities could that open up for interventions, perhaps even preventative ones down the road, if we can identify people at risk before significant degeneration kicks in? That's a fascinating space to watch.
It really raises an important question about how our growing scientific understanding will actually translate into future clinical practice and hopefully potential treatments.
Absolutely. Well, thank you for joining us on this deep dive into FTD. We really hope this exploration has been valuable for your learning journey.
Keep digging, keep asking questions. It's the best way to learn.
And remember, if you're looking for more resources specifically for your MSRA revision, be sure to check out passthemsra.com.
And for a range of free revision materials, you can visit freemsra.com.
Until our next deep dive.